Dr. Abdulhadi, if you are ready, you can go ahead and share your slides and get ready. Thank you.
Thank you.
Okay, Dr. Abdulhadi, you can go ahead and start.
Okay, Assalamu alaikum. Bismillah. I'm Abdulhadi Alama, and my topic is about the descending thoracoabdominal aortic aneurysms. We'll start by a brief review of the anatomy. The descending aorta is the largest part of the aorta. It arises as a continuation of the aortic arch after the branching of the left subclavian vein, the subclavian artery, at the level of the T4 thoracic vertebrae. It courses downwards through the posterior mediastinum. Initially, it is found left to the vertebral column, but as it descends, it inclines toward the midline and ends up being anterior to the lower border of the body of T12 vertebrae. At this level, it passes through the aortic orifice of the diaphragm into the abdomen and transitions into the abdominal aorta. It gives off multiple small branches, such as the pericardial branches, bronchial branches, esophageal branches, mediastinal branches, posterior intercostal and subcostal branches, and superior phrenic branches. The abdominal aorta begins its course anterior and to the left of the vertebral column and continues downwards, reaching the lower part of L4 vertebrae. At this level, it terminates by bifurcating into the right and left common iliac arteries, gives off several important branches, including the celiac trunk, the superior mesenteric artery, the right and left renal arteries. It gives off other branches as well, including the inferior mesenteric arteries, the suprarenal arteries, gonadal arteries, lumbar arteries, inferior phrenic arteries. Now we'll jump to our main topic, the thoracoabdominal aortic aneurysms. These are the normal dimensions of the aorta. By definition, an aneurysm is a dilatation of an artery with a diameter at least 50% greater than the normal size of that artery. Aneurysmal degeneration can occur anywhere in the aorta, either thoracic, abdominal, or thoracoabdominal. Most occur in the abdominal aorta. The media of the aorta normally contains elastin, collagen, smooth muscle cells, and ground matrix. Aneurysms form after loss of the smooth muscle cell and fragmentation of elastin fibers. This process is known as cystic media degeneration, which results in loss of elasticity and tensile strength of the media. The aorta normally expands and recoils with systole and diastole, but dilates when the elastic recoil is lost. Predisposing factors for developing the aneurysms, it's A, B, C, D, E. A for age and atherosclerosis, B for bicuspid aortic valves and blood pressure, the hypertension. C for connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome. D for dissections and degenerations of the cystic media. E for emergency trauma, aortitis, infection, and syphilis. The aortic aneurysms can be classified based on etiology, shape, or extent. The most important is the extent. We'll go through that later. We'll first go through the etiologies, either atherosclerotic, dissecting, or mycotic. The shape can be either saccular or fusiform. A fusiform aneurysm has a uniform shape with a symmetrical dilatation that involves the entire circumference of the aortic wall. A saccular aneurysm, however, is a localized outpatching of the aortic wall, similar to a hernia. The classification based on extents, the most widely used classification is the Crawford's classification of thoraco-abdominal aortic aneurysms. The extent one involves the majority of the descending thoracic aorta as well as the upper abdominal aorta. It arises from above the sixth intercostal space, usually near the left subclavian artery, and extends to include the origin of the celiac axis, superior mesenteric artery. Although the renal arteries can be involved, the aneurysm does not extend into the infrarenal aortic segment. The extent too, as you can see in the picture, it involves the majority of the descending thoracic aorta and the majority of the abdominal aorta. So they also arise above the sixth intercostal and extends distal to include the infrarenal aortic segment, often to the level of the aortic bifurcation. That's why most of the times when we explain about management or operative planning, most of the talk will be about the extent too, because it incorporates all other extents. Extent 3 involves the lower descending thoracic aorta and the majority of the abdominal aorta. They arise in the distal half of the descending thoracic aorta, below the sixth intercostal space, and extends into the abdominal aorta. Extent 4 involves most or all of the abdominal aorta from the level of the diaphragm to the aortic bifurcation. Extent 5 involves the lower descending thoracic aorta and the upper abdominal aorta. They arise in the distal half of the descending thoracic aorta below the sixth intercostal space and extends into the abdominal aorta, but is limited to the visceral segment. Clinical presentations of these thoraco-abdominal aortic aneurysms, they are usually asymptomatic until they expand or rupture. An expanding abdominal aortic aneurysm can cause sudden, severe, and constant low back pain, flank pain, abdominal pains, or groin pains. Most clinically significant aneurysms are palpable in the abdomen on routine examination. The presence of a pulsatile abdominal mass is diagnostic, but is found in less than half of all cases. Patient with a ruptured abdominal aortic aneurysm may present with a sudden onset of severe abdominal pain and hypovolemic shock. Patients could have normal vital signs in the presence of a ruptured abdominal aortic aneurysm due to the retroperitoneal containment of the hematoma. When diagnosing aortic aneurysms, ultrasonography can be very useful as a screening or to rule out the diagnosis, but it has the limitation of being limited to the abdominal aorta, and it cannot visualize the thoracic part. CT angiography is the main modality for divining and planning open or endovascular repair. It can visualize the entire aorta and its branches, and it can identify any dissections or ruptures. Conventional angiography is rarely indicated to define the anatomy. MRIs can also be used. However, they are rarely needed. Therapies are designed to limit the growth of aneurysms by decreasing stress on the aortic wall. In general, avoiding high-intensity exercises, such as weightlifting, as aortic pressure may increase rapidly and exert significant stress on the aortic wall. Additionally, exercises with rapid bursts of acceleration and deceleration, such as basketball, may place excessive stress of aortic wall. Beta blocker therapies aim to decrease the overall blood pressure and to decrease the change in aortic pressure over time to diminish the stress applied to the aorta in systole, thereby limiting damage to the medial layer. Surgically untreated thoracic aortic aneurysms carry the risk of rupture, dissection, and death. Therefore, when talking about the indications for intervention, the first indication is the expansion of thoracic aneurysms that occur at a faster rate in larger aneurysms. The expansion can occur at a rate of 0.2 centimeter per year in aneurysms that are less than 5 centimeter, compared to 0.8 centimeter per year in aneurysms that are more than 5 centimeters, as per the Laplace law. The risk of rupture increases as the size of the aneurysm increases, 0.3% per year for aneurysms that are less than 5 centimeter, 4 to 5 centimeters, compared to 3.6% chance of rupture per year for aneurysms that are more than 5.5 centimeters. So definitely a diameter of more than 5.5 centimeter is an indication of intervention. Any aneurysms that produce symptoms of expansion, compression, or fistula formation, such as chest pains, back pains, dyspnea, dysphagia, hoarseness, hematemesis, or hemoptysis, they are also indicated for intervention. A rapid rate of expansion of more than 1 centimeter per year is also indicated for expansion. And any thromboembolic events that are attributed to the aneurysm is also an indication for intervention. The interventional options are the endovascular repair, either TEVAR or EVAR, which will be covered by my colleague in the next talk, the open surgical thoracoabdominal repair, and a hybrid approach, an endovascular repair for the thoracic part and an open surgical repair for the abdominal part. I'm going to be focusing on the open surgical thoracoabdominal repair. And as I mentioned before, we're going to talk about the extent to aneurysms. In preoperative planning, basic patient characteristics and labs and should all be performed, basic renal profile, coagulation profile, as any other surgeries. And an important addition is the echocardiogram should be performed to assess the cardiac function, as well as a pulmonary function test. As most of these patients will undergo single lung ventilation, pulmonary function test is necessary. Carotids should also be screened to detect any stenosis, which would increase the risk of stroke. A complete neuromuscular exam should be performed before and after the surgery. In the anesthesia preparation, in addition to the routine anesthesia preparations, they should have a dual arterial line, one in the right arm and one in the left or the lower limb, ideally in the lower limb. This is just to measure the pressures while we are on clamp. A spinal drain is placed for spinal protection, which also going to be covered by today's talk by another colleague. A double lumen endotracheal tube is used to isolate the left lung during the thoracic aortic exposure. And the patient is usually positioned in a semi-left lateral position with the shoulders at 60 degrees and the hips at 30 degrees, as you can see in this picture. Moving on to our incision. Sometimes it's called a sigmoid-shaped skin incision. It is made from just posterior to the inferior aspect of the left scapula, curving along the 7th rib and across the costal margin towards a point approximately 2 centimeters to the left of the umbilicus. A regular thoracotomy is carried out to provide entry into the plane of the rib cage. To provide entry into the abdominal aorta, the dissection is carried out in the paramedial plane lateral to the rectus muscle, going laterally to reach the retroperitoneal space. The peritoneum is not opened and it is retracted medially with its contents as a hernial sac. The left hemidiaphragm is separated from the left chest wall to enhance exposure. At this stage of the surgery, after we've identified the aorta, it's important to identify the important branches that we need to pay attention to, which are mostly the celiac trunk, the superior mesenteric artery, and the right and left renal arteries. In addition, we should expose and dissect a good area for our proximal anastomosis and the proximal clamp, and a distal anastomosis and distal clamp. The repair can be carried out using the traditional clamp and saw technique. However, it is associated with a higher complication rate and requires fast and speed surgery. So a bypass circulation can be used to facilitate this repair. One option is to use a left heart bypass, as shown in the picture. You can see the drainage is going from the pulmonary vein before the left atrium, and going all the way to the pump and pumping into the abdominal aorta. That's called the left heart bypass, and it does not require an oxygenator. Another option is to cannulate the femoral artery and the femoral vein to perfuse the distal body and go just on a regular peripheral bypass. In both options, after the cross-clamping of the aorta, the upper body will be perfused by the heart and the lower body will be perfused by the bypass pump. So care must be taken to maintain adequate pressure in both segments. The heart should not be emptied excessively by the perfusionist because that will drop the pressure in the upper body. So good communication between the anesthesiologist and the perfusionist must be in place. The use of the bypass machine also provides selective perfusion to the visceral branches of the aorta during the repair, which we'll show you in a minute. After applying the proximal and distal cross clamps and controlling the visceral branches, the aorta is opened longitudinally. At this stage, an ostial cannulas, same as we use for the coronary cardioplegia, can be used to perfuse the visceral branches, the celiacs, SMA, and right and left renal arteries. Any back bleeding that is observed from a lumbar or intercostal branches, they are usually sawed off unless they are big enough to be anastomosed to the graft. As you can see in this picture, they have chosen to anastomose some of the intercostal, subcostal branches to the graft. And here is our proximal anastomosis. This is the stage where the proximal anastomosis is carried out after the selective perfusion. The celiac, SMA, and the right renal arteries can be anastomosed as one island or individually to the graft. In the picture, they are shown to have anastomosed as one island. The left renal is usually anastomosed individually. The proximal clamp is moved distally after each anastomosis to maintain perfusion. The distal anastomosis is then carried out, followed by removal of the clamp and performing hemostasis. Then decannulation and closure can be done. At this stage, we've completed our repair, and the abdomen can be closed. These were my references, and thank you. Any questions?
Thank you, Abdul Hadi, for the nice presentation.
Thank
Very
you.
informative. Again, any questions or comments from our audience? Okay. If there are no interactions at this point, we can take a 5-minute break until 1:30, and then we'll resume with our second lecture, endovascular therapy for the treatment of thoracic aortic disease by Dr. Anwar Al-Halabi. Okay, Dr. Anwar, can you share your slides, please? Can you hear me?
Okay, you can hear me?
Yeah, but your voice is a bit low. It's like it's distant a little bit.
You can hear me now? Is
Yeah,
better?
yeah, this is better. Go ahead. Are you having an issue sharing your slides?
I'm trying now to share them.
Okay. Do you need help?
Can you just give me 5 minutes? I have some technical issue.
Okay.
You can see my slides now?
Yes.
Okay. Okay. Um, I'm sorry for the delay. I'm Anwar Al-Flabi, and today I will speak about the endovascular therapy for the treatment of thoracic aortic disease. So this is the outline for my presentation. We will start with an introduction, then the history, then specific pathologies and current guidelines. We will speak about the principle of TVAR. So as an introduction, patients with thoracic aortic disease poses many challenges. They are frequently older and present with multiple comorbidities. Additionally, the posterior location of the descending thoracic aorta requires a large thoracotomy incision with its own inherent morbidity. The modern surgical treatment of the thoracic aortic disease began in the 1950s when successful treatment utilizing segmental resection and graft replacement was first reported. Soon thereafter, DeBakey and Coley reported the first successful repair of an ascending aortic aneurysm using cardiopulmonary bypass. For improved diagnostic capabilities, surgical techniques, and perioperative care have resulted in improved outcomes, even as the risk profile has worsened. So, in an effort to limit the morbidity for these operations, the endovascular techniques have been emerged. Although the endovascular treatment originally was intended for the treatment of or the repair of atherosclerotic thoracic aortic aneurysms, thoracic stent graft application have been expanded to the treatment of multiple pathologies, including acute and chronic aortic dissection, penetrating atherosclerotic aortic ulcers, and thoracic aortic trauma. Thoracic endovascular aortic repair, or what is called TVAR, is a minimally invasive technique, and it is now the preferred treatment, replacing the traditional method of open replacement of the descending thoracic aorta for the majority of the descending thoracic aortic disease. Endovascular stent graft technology was initially targeting the abdominal aortic aneurysm, which was introduced by Parodi, in which the first stent was a self-expanding Z stents, which were fastened together and covered with a woven Dacron graft and then compressed into 28 French introducer sheet. So the first homemade thoracic graft was implanted in the descending thoracic aorta in the 1992. However, this first generation stent graft have some anatomical constraints which preclude either the delivery or secure the fixation of these grafts. And these including small iliofemoral vessels, acute angulation of the distal arch, a severe sigmoid-like tortuosity through the diaphragmatic crura, and excessive neural thrombus. In the 2005 and 2006, the Gore excluder tag system was approved, and these stents contains a thin-walled polytetrafluoroethylene graft, which was covered by a nitinol exoskeleton. Shortly, this was followed by a Medtronic Talent graft and the Koch Zenith graft, as we can see in these pictures. So these second and the third generation endoprosthesis addresses many of the deficiency of the early homemade devices. So the delivery system have become increasingly smaller in diameter and more flexible, and the exoskeleton provide a high column strength and be compression and kink resistant. In January 2005, the phase 2 multi-center trial of the Gore excluder tag thoracic endoprosthesis was reported. And this multi-center prospective non-randomized trial was conducted at 17 sites and compared the results of a stent graft repair of the descending thoracic aortic aneurysm in 140 patients with the results of an open repair in 94 patients. This study include strict inclusion and exclusion criteria in an attempt to ensure the comparability of both groups. Follow-up CT scan were obtained at 1, 6, 12, and 24 months. So they found that for stent graft patients, operative blood loss, renal failure, paraplegia, and mortality rates were all significantly less than for open repair group. Moreover, ICU stay and total hospital stay and time to return to normal activity were approximately 50% shorter for the stent graft group than for those with an open repair. However, the stroke rates were approximately equal in both groups, and although the stent graft patients have a reduced aneurysm-related mortality up to 2 years, 3% in the stent graft patients versus 10% in an open repair. However, the all-cause mortality was similar between two groups at 2 years. So moving on now to the specific pathologies and the current guidelines. Here I will speak about the recent guidelines, the 2022 American Heart Association guidelines for the diagnosis and management of the aortic disease. The first pathologist is the thoracic aortic aneurysm. Approximately 50% of all thoracic aortic aneurysm are located in the descending aorta, and these aneurysms commonly arise at the level of the left subclavian artery. They are often atherosclerotic in nature, and the thoracic aortic aneurysm have an overall 5-year rupture risk of 30%. This is the risk factor for the aortic rupture in patients with the descending thoracic aortic aneurysm, like aneurysm growth of more than or equal 0.5 centimeter per year in symptomatic patients or symptomatic aneurysm, and syndromatic patients like Marfan syndrome, the Ehlers-Danlos syndrome, and other syndromes. In acicular aneurysms, female sex, and infectious aneurysms. So what about the size threshold for the repair of the descending thoracic aortic aneurysm? They found that in patients with intact descending thoracic aortic aneurysm, the repair is recommended when the diameter is more than or equal 5.5, and this is a class 1 indication. In patients with intact descending thoracic aortic aneurysms and risk factor for rupture, as we discussed previously, the repair may be considered at that diameter of less than 5.5 centimeter, depending on the risk factor itself. And in patients at increased risk for perioperative morbidity and mortality, it may be reasonable to increase the size threshold for surgery accordingly, and this is a class 2B. And this table shows the patient characteristics associated with increased the perioperative morbidity and the mortality for an open and the endovascular repair. For example, for an open surgical repair, advanced age, the presence of preoperative renal insufficiency or hemodialysis, COPD patient and the previous stroke. For the endovascular repair, the extent of the aneurysm itself, like a thoracoabdominal aortic aneurysm, the presence of pulmonary disease, the need for the iliac access, and zone 1 or 2 landing for the thoracic stent graft. And we will speak about the aortic zones later on. Why they choose this size threshold? Because they found that if the aortic diameter, if the increases, the definite and the probable aortic event increases. What is the definite and the probable aortic event? The definite aortic events include aortic dissection or rupture confirmed with imaging or intraoperative findings, and the probable aortic events include a definite aortic events as well as sudden unexplained death. So at aortic diameter of 5.5 centimeter, the definite aortic events is 7.2%, and the probable aortic events is 11.2%. And if the aortic diameter increases up to 7 centimeter, the definite aortic events it will increase to 15%, and the probable aortic events will increase to up to 30%. That's why they choose the threshold for the intervention. Open surgical graft replacement has been the traditional mainstay of treatment for these patients, and the mortality rates up to 10% have been reported from the experienced centers. However, endovascular repair have become increasingly attractive, especially in elderly population with multiple comorbidities and favorable anatomy. Also, coverage of the left subclavian artery to create a satisfactory proximal landing zone has been frequently employed with a few complications. And pre-op left subclavian to carotid transposition needs to be done only for extensive thoracic coverage, diminutive right vertebral artery, impaired perfusion of both left subclavian and hypogastric arteries, and for patients with the previously repaired abdominal aortic aneurysm. Patients considered at high risk for paraplegia should receive a spinal drain. Pre-op and hypotension should be avoided as much as possible. Okay, endovascular versus open repair for the descending thoracic aortic aneurysm. In patients without syndromes, who have a descending thoracic aortic aneurysm that meets the criteria for intervention and the anatomy that is suitable for endovascular repair, TEVAR is a class 1 indication. In patients with descending thoracic aortic aneurysm that meets the criteria for repair with TEVAR, however, they have a small or disease access vessels, consideration for an alternative vascular access is class 1 indication. And in patients with descending thoracic aortic aneurysm that meets the criteria for intervention, who have anatomy unsuitable for endovascular repair, and who are without significant comorbidities and the life expectancy of at least 10 years, open surgical repair is a class 2A indication. What about ruptured descending thoracic aortic aneurysm? So in patients with a ruptured descending thoracic aortic aneurysm who have an anatomy that is suitable for endovascular repair, TEVAR is class 1 indication because of the decreased perioperative death and morbidity. And in patients with ruptured descending thoracic aortic aneurysm who are undergoing TEVAR, intentional coverage of the left subclavian artery, celiac artery, or both may be considered to increase the landing zone for the endovascular repair so that it will increase the success of the repair, and this is a class 2B indication. Moving on to the thoracic aortic dissection. Perhaps the greatest impact of this endovascular technology has been on the treatment of thoracic aortic dissection. And as you know that the aortic dissection can be classified into type A and type B as per the Stanford classification. And type B aortic dissection also can be classified as complicated and uncomplicated. So what is the criteria for the complicated acute type A aortic dissection? The first one is the rupture, either free or contained rupture. There is a branch artery malperfusion, either complete or partial. If the dissection is extended either proximally or distally, if there is a progressive enlargement of the true, false, or both lumens, if the patient is complaining of intractable pain or uncontrolled hypertension. So any one of these criteria, if they are present, the type B aortic dissection is called complicated one. What about the uncomplicated acute type B aortic dissection? There is some risk factor, some risk features that make this uncomplicated type B aortic dissection a high risk. And it can be divided into imaging findings and clinical findings. In clinical findings, if there is a refractory hypertension despite more than 3 different classes of antihypertensive medication, or if there is a refractory pain that is persisting more than 12 hours despite maximal recommended doses of painkiller, or the patient needs of readmission. And the imaging findings include a maximum aortic diameter of more than 4 centimeters, if the false lumen diameter of more than 20 to 22 millimeter, if the entry point is more than 10 millimeter, or if the entry tear is on the lesser curvature of the aorta, or there is a bloody pleural effusion, or there is an image evidence of malperfusion. So this is considered as a high risk features for the uncomplicated acute type B aortic dissection. So previously, open repair of complicated acute type B aortic dissection was associated with high mortalities. So the endovascular repair has emerged because of its ability to cover the primary entry tear, thus redirecting the flow into the true lumen and eliminating both the dynamic malperfusion and the static malperfusion during the same interventional setting. So what is the difference between the static and the dynamic malperfusion? The static malperfusion occurs when the dissection flap extends from the aortic lumen into the ostium of the affected branch vessels, leading to localized thrombosis of the branch vessels or the false lumen that narrow or occludes the branch true lumen and consequently will impair the distal branch perfusion. The dynamic malperfusion will occur when the false lumen becomes persistently pressurized and compresses the true lumen. So this in turn will push the dissection flap against the ostium of the affected branch vessel, and this will reduce or occlude its flow. And sometimes a branch vessel can suffer from both static and dynamic obstruction at the same time. So what is the management of acute type B aortic dissection? So in all patients with uncomplicated acute type B aortic dissection, medical therapy is the class 1 indication. And in patients with complicated acute type B aortic dissection, so intervention is recommended and it is a class 1 indication. So if the complication is rupture, the endovascular stent grafting is a class 1 indication if the anatomy is suitable for the endovascular technique. And if it is, and if there is other complication other than the rupture, so the use of the endovascular approach is also class 2A. In patients with uncomplicated acute type B aortic dissection, but have a high risk anatomical features that we discussed about it previously. So the endovascular management is the class 2B. Now, moving to penetrating atherosclerotic ulcer and intramural hematoma. What is intramural hematoma? Intramural hematoma describes the presence of blood within the medial layer of the aortic wall in the absence of an overt intimal tear or patent false lumen, and the blood here may arise from either rupture of the vasa vasorum causing bleeding within the media or small intimal tear that are not visualized on a standard imaging examination. The intramural hematoma is diagnosed by CTA, MRI, and echo by the presence of a circular or crescent-shaped thickening of the aortic wall of more than 5 millimeters in the absence of detectable blood flow. And the natural history of intramural hematoma is variable, in which fewer than 10% were resolved to aortic dissection, the intimal tear ruptures and create an entry tear. Also, the intramural hematoma can be classified as type A and type B, the same as the dissection. And the type B also can be complicated. And what is the feature of the complicated intramural hematoma? Malperfusion, dry aortic hematoma, pericardial effusion with cardiac tamponade, persistent refractory or recurrent pain, or the presence of rupture. So, in patients with complicated intramural hematoma, urgent repair is a class 1 indication. In patients with acute type B intramural hematoma, the medical therapy is a class 1 indication as the initial treatment strategy. And in patients with acute with type B intramural hematoma who require repair of the distal aortic arch or descending thoracic aorta and have anatomy that is suitable for the endovascular repair. So the endovascular repair is a class 2A. And in patients with acute type B or intramural hematoma who require repair, however, the anatomy is unfavorable for endovascular repair, so open surgical repair is a class 2A. Now, what is the penetrating atherosclerotic ulcer? Penetrating atherosclerotic ulcer begin with an ulceration of the atherosclerotic plaque, which leads to a focal disruption of the aortic intima that allow blood to penetrate into the medial layer, and it's often associated with an intramural hematoma of variable size. And it's most often appear in the middle or distal descending thoracic aorta, less frequently in the aortic arch and the abdominal aorta, and rarely can be seen in the ascending aorta. So, the management of the penetrating atherosclerotic ulcer can be divided into two. If the penetrating atherosclerotic ulcer is present with intramural hematoma or rupture, or if it is isolated one. So we will start with the penetrating atherosclerotic ulcer is associated with rupture or intramural hematoma. So if it is associated with rupture, the urgent repair is a class 1 indication. If it is associated with intramural hematoma of the ascending aorta, the urgent repair is a class 1 indication also. If it is associated with intramural hematoma of the descending thoracic aorta or the aortic arch, the repair is a class 2A. And if it is associated with intramural hematoma of the abdominal aorta, so the repair is a class 2B. In cases of isolated penetrating atherosclerotic ulcer, so it will depend on if the patient is symptomatic or not. If the patient is symptomatic and have persistent pain that is clinically correlate with the radiological findings, so repair is a class 1. If the patient is asymptomatic but have a high risk imaging feature, so elective repair is a class 2B. And this is the high risk imaging feature of the penetrating atherosclerotic ulcers, as you can see them in the table. what about an open surgical repair versus an endovascular repair? So patients with the penetrating atherosclerotic ulcer of the ascending aorta or the proximal aortic arch, open repair is a class 1 indication. In patients with penetrating atherosclerotic ulcer of the distal aortic arch or the descending or the abdominal aorta, either the open repair or endovascular repair is reasonable, and this is a class 2A. Now, lastly, the thoracic aortic trauma. The aortic injuries secondary to non-penetrating trauma are frequently lethal lesions, with up to 90% of patients dying in the hour after the accident. Urgent surgical graft replacement of the aorta has been the conventional treatment, but these patients frequently having other major injuries, including closed head injuries, pulmonary contusions, myocardial contusions, and other solid organ injuries, which may limit the option of surgical repair. Blunt aortic injuries have been classified into 4 classes. Grade 1, which involves only an intimal laceration with no other radiological changes. Grade 2 injury includes an intimal laceration and mild intramural hemorrhage without significant compromise of the visual lumen. Grade 3 injury include an intramural hemorrhage sufficient to cause an increase in the aortic diameter and compression of the intimal lumen, and this is what is called the classical pseudoaneurysm. Grade 4 injury that involves rupture or impending rupture. So, what is the initial management of blunt traumatic thoracic aortic injury? So, in cases of grade 1 injury, non-operative management and follow-up imaging is a class 1 indication. In cases of grade 3 and 4, and the patient having non-prohibitive comorbidities or injuries, aortic intervention is a class 1 indication. In cases of grade 2 injury and high-risk imaging features, as we can see them in the table, in the next table. So aortic intervention is the class 2A. And in cases of grade 2 injury, but without high-risk imaging features, so non-operative management and follow-up surveillance using imaging is the class 2B. In patients with in patients who require intervention for the blunt traumatic thoracic aortic injury and have a favorable anatomy, so TEVAR is a class 1 indication. Moving on to the principle of TEVAR. So the principle of TEVAR is the exclusion of the aneurysm or dissection with the use of self-expanding covered stent. And the placement of this stent is through the femoral artery in most cases under imaging guidance, and requires an adequate landing zone for the stent graft proximal and distal to the aortic lesion of at least 2 centimeters. Now we will speak about the aortic landing zones. What is the landing zone? The landing zone is an area of the aorta without the disease that's used to land the stent safely. And the aorta can be divided into 11 zones, 6 of which are in the thoracic aorta, which are useful for describing the segment of the vessels and the potential branches that may be covered or replaced during the repair. Zone 0 involves the ascending or distal involves the ascending aorta to the distal end of the origin of the innominate artery. Grade 1 or zone 1 involves the origin of the left common carotid between the innominate and the left common carotid artery. Zone 2 involves the origin of the left subclavian artery between the left common carotid and the left subclavian. Zone 3 involves the proximal descending thoracic aorta to the T4 vertebral body. So, and it is usually the first 2 centimeter distal to the left subclavian artery. Zone 4 involves the end of the zone 3 to the mid descending aorta, which is about the up to the T6 vertebral body. Zone 5, the mid-descending aorta to the celiac arteries. Zone 6 involve the origin of the celiac to the superior mesenteric artery. Zone 7 involve the origin of the superior mesenteric artery to the renal arteries. Zone 8 involve the origin of the renal arteries to the infrarenal abdominal aorta. Zone 9 involve the infrarenal abdominal aorta to the liver of the aortic bifurcation. Zone 10 involves the common iliac, and zone 11 involves the origin of the external iliac arteries. So, what is the complication of TIVA? The most common complication is the endoleak. And the endoleak is the leakage of blood into the aneurysmal sac after the stent graft placement procedures. And this may progress to aneurysmal rupture. The other complication can include a neurological complication, including permanent, complete or incomplete paraplegia, reversible spinal cord ischemia, transient stroke, or permanent stroke. Now, endoleaks have many types, and it can be classified into 5 types. Type 1 endoleak, which occur at the proximal, and this is called type 1A, or the distal, and it is called type 1B. Attachment sites and signify a failure to achieve a hemostatic seal at these implant sites. Type 2 endoleak, which involves a backfilling of the aneurysmal sac through a branch vessels of the aorta. Type 3 endoleak, which is including a graft defect or component misalignment. So there is a defect inside the graft. Type 4 endoleak, which is a leak through a graft fabric as a result of graft porosity, and it's often resolved with the cessation of anticoagulation. Type 5 endoleak, which is a continuous expansion of the aneurysmal sac without a demonstrable leak on imaging, and this is called an endotension. And this is possibly results from aortic pressure that is transmitted through the graft to the aneurysmal sac. So as a conclusion, TVAR is the preferred choice of intervention for patients with descending thoracic aortic conditions. Sufficient seal zones, safe pre-op planning, and suitable device sizing are important to obtain good results and reduces the complications. With the accumulation of expertise and improvement of device imaging, TVAR has improved to be safer and has the potential to expand the treatment choices to include the ascending and arch pathologies in the future. So this is my references, and thank you. If you have any questions, I'm up to taking any question.
Thank you, Dr. Anwar. Anyone has any question for Dr. Anwar? If no questions, we can take 5 minutes break and resume at 2:20.
السلام عليكم سلطان.
عليكم السلام. هلا عبد الله اسمعني؟
If you're ready, you can share your presentation.
اوكي، تسمعني كويس؟
تمام الحين نسمعك.
Okay. بسم الله الرحمن الرحيم. I'm Sultan Amro. Today we'll talk about spinal cord protection during aneurysm repair. We'll go through a small introduction, then we'll talk briefly about anatomy and protection techniques. Spinal cord ischemia is one of the major complications that may follow descending aortic intervention. Spinal cord ischemia may cause several degrees of neurological deficit, from temporary or permanent paraparesis to complete flaccid paraplegia. Neurological damage may be immediate or delayed. For immediate spinal cord ischemia, usually result from hypoperfusion. A delayed deficit may be due to a reperfusion mechanism. To understand the extension of the surgical repair, we will go through Crawford classification. Which classified the thoracoabdominal aortic aneurysm based on the extent of aortic involvement. For extent 1, we have repairs that involve replacing most of or all thoracic descending thoracic aorta and the upper part of abdominal aorta. For extent 2, which is the same for extent 1 from proximal, which involve most of or all the descending thoracic aorta and extend into the infrarenal abdominal aorta. For extent 3 repair, it involve the distal half or less of the descending thoracic aorta and varying portion of abdominal aorta. For extent 4 repairs, it involve most or all of the abdominal aorta. No thoracic aortic involvement. The blood supply to the spinal cord is surprisingly meager considering the importance of this nervous tissue. The main blood supply to the spinal cord is via single anterior spinal artery, which is formed by the union of two vertebral arteries that originate from first part of subclavian artery, and two posterior spinal arteries that originate from a posterior inferior cerebral artery, a branch of vertebral artery. Blood supply of the spinal cord reinforced by segmental arteries that branching from dorsal aorta and cervical vertebral arteries increase spinal blood supply for segment of spinal cord, and it's more prominent in cervical and lumbar enlargement of spinal cord. Segmental arteries branching into anterior and posterior radicular artery, and also anterior and posterior medullary artery. Medullary artery will go to reinforce the blood supply to the anterior and posterior spinal arteries. The radicular arteries will supply the surface of the spinal cord. About protection technique, historically, the rate of spinal cord deficit have been as high as 30% for extent to aortic replacement. But with the improvement of protection technique, it's decreased now to around 5%. The first technique, protection technique for spinal cord during aneurysm repair, is the cerebrospinal fluid drainage, which enhance the spinal perfusion by decreasing the pressure on the cord during aortic cross-clap. It's recommended by current US practice guidelines during both open and endovascular repair in patients at high risk of developing paraplegia. High risk, we mean class 1, extent 1, and extent 2 repair. So it's a class 1 recommendation. Risk with using the cerebrospinal catheter include the intracranial bleeding, perispinal hematoma, meningitis, and spinal headache. The catheter is placed through the second or third lumbar space preoperatively and after the induction of anesthesia, and usually maintained for 1 to 2 days post op. CSF pressure will be maintained between 8 to 10 during the procedure and between 10 to 12 during the early post-operative period. After we make sure the patient has no deficit and confirm the neurological examination, confirm that he can move his legs, we can go for higher CSF pressure between 15 to 18, but usually not to exceed 25. The other protection technique is the left heart bypass. It's used for as we go more for more extensive repair, so we get more or greatest benefit by left heart bypass. So usually it's proving that it reduces the incidence of spinal cord deficits only in extent 2 repairs, but still routinely used to provide distal aortic perfusion during proximal portion of aortic repair in patients with extent 2 and 1. Because it gives the surgeon more time to create secure anastomosis. Other technique is the use of segmental artery reattachment. Usually you have to go aggressive. We have to do aggressive approach to reattach patent segmental arteries because the weak nature of blood supply to the spinal cord. So a pair of patent segmental arteries from T2 to L1 are selectively reattached as patches to one or more opening that made it in the graft. And arterectomy of aortic wall and removal of calcified intimal disease can be considered if none of these segmental arteries are patent. For reattachment, usually we have different approaches. Either we anastomose the segmental arteries pairs as an island to an opening through the graft. The second thing is direct single end-to-end anastomosis with a separate graft to the main aortic graft, or side to side, end to side with a loop graft that attached to aortic graft. After intercostal arteries are reattached, the proximal clamp is often usually moved down the graft to restore intercostal perfusion. Sequential clamping restore perfusion to the proximal branch vessels and will decrease ischemic time to the spinal cord. Spinal cord monitoring is considered as a protective technique. It gives intraoperative assessment of spinal cord function. We have different type of spinal cord monitoring. For example, we mentioned the somatosensory evoked potential and the motor evoked potential monitoring. For motor evoked potential monitoring, it involves electrical excitation of a motor cortex or motor neurons and measuring the amplitude of the resulting motor response in the peripheral muscles in the arms and legs. The spinal cord monitoring allows real-time assessment of spinal cord function. And for comparing, we find the motor evoked potential is more sensitive indicator of spinal cord ischemia than somatosensory evoked potential because the motor function of the anterior horn of the spinal cord is more susceptible than posterior horn of ischemia and infarction. Irreversible loss of either motor or somatosensory evoked potential is predictive of immediate neurological deficit. The problem with the spinal cord monitoring the evoked potential we mentioned is preclude the use of neuromuscular paralytic agent during the procedure, which add complexity on anesthetic management. And also there's still a risk of false positive result. Regional spinal hypothermia, we can reach, it can be done as a direct infusion of cold perfusate into the epidural space and by intravascular cold perfusion of isolated thoracic aortic segment. It's reduced the incidence of spinal cord ischemia, ischemic injury from around 20 to 10% in some studies. In animal models, cold perfusion into isolated aortic segment has been tested to show that core temperature and consequently the extent of ischemic spinal cord injury can be effectively reduced by this method. The collateral network concept. This concept that network of indicate that a network of small arteries that perfuse the spinal cord may remodel following ischemic insult to provide sufficient perfusion. This theory enhanced the improvement of endovascular spinal cord preconditioning techniques by selectively coiling segmental arteries to promote remodeling and better tolerates subsequent open distal aortic repair. Also, this theory is supported by that staged distal aortic repair facilitate remodeling of the spinal cord perfusion between repairs. Prevention of postoperative spinal cord ischemia. Post-operative management to enhance spinal cord protection is is usually started with maintaining adequate blood pressure, preload, and cardiac inotropic status to keep spinal perfusion sufficient. Usually, if there is no bleeding, the blood pressure should be kept near its preoperative baseline levels. Delayed spinal deficit can rise hours to days after aortic surgery. If patient already developed post-operative spinal cord deficit, there is some to manage this patient to try to recovery for trial of recovery. We start an immediate post-operative period. We start to increase blood pressure, replacing cerebrospinal fluid drain and decreasing CSF pressure. Also, the use of mannitol and steroids with the correction of anemia. If these measures, the patient did not recover after that, so his recovery is not likely. Thank you.
Thank you, Sultan. Nice presentation, concise and to the point. Have you in your center seen anybody use it, spinal drainage system during aortic surgery? I don't know if it's that common in practice or not.
Spinal, which one? Sorry.
The spinal cord protection strategy, spinal drainage system. Is it usually used? Have you?
Yeah. I saw the usage of CSF catheter. This is what usually this is what I saw in a couple of cases.
Nice.
But the other, the cooling and the one is I did not see. Also, I did not see many cases of open aortic repair. So the reattachment was not in consideration.
Okay. Thank you. Anyone has any questions or comments or additions? Okay. Thank you, Sultan, again. Thank you, everyone. And I believe by this we conclude our session for today.
Thank you.
Thank you. Salam.